The final weeks of human gestation initiate a highly complex systemic preparatory sequence that begins deep inside the uterine environment. During this phase, the primary clinical symptom a patient experiences is sudden, intense abdominal tightening. This presents a central diagnostic paradox. This exact physiological sensation can signify a harmless biological drill or the initiation of childbirth. Misinterpreting this symptom carries a heavy operational cost. It leads to premature hospital admissions and unnecessary medical interventions. Conversely, dismissing the sensation carries a more severe danger: perilous delays in securing care during active, rapid delivery. Relying solely on subjective pain scales to diagnose labor is inefficient. The process requires identifying objective physiological markers. Diagnosis depends on isolating localized muscular spasms from systemic progressive physiological changes. Identifying labor involves mapping the biomechanical timeline to see if a positive feedback loop is currently active. This transition from localized cellular practice to a synchronized endocrine sequence is the specific shift we must track to confirm the onset of delivery. We can begin by examining the clinical presentation of false labor, medically known as Braxton Hicks contractions. Physiologically, this state occurs when the myometrium, the middle layer of the uterine wall, undergoes localized, non-patterned muscular preparation. The specific, measurable clinical markers of this preparatory phase are irregularity in timing and unpredictability in duration. This graph plots Fatima's irregular, low-amplitude contractions. When she hydrates, tension is disrupted and spikes arrest. Right. True labor operates as an irreversible systemic progression. Aisha's contractions appear at precise 10-minute intervals, accelerating to 5, then 3-minute gaps, with steadily increasing amplitude. The defining characteristic of this progression is its inescapability. The intervals mathematically tighten regardless of patient intervention. Unlike false labor, true myometrial progression cannot be arrested by rest, water, or positional changes. What begins as mild clinical discomfort biologically shifts into rhythmic, escalating mechanical strain. The rigid pattern of contractions, not the isolated sensation of pain, confirms active parturition. True labor contractions are defined strictly by predictable temporal acceleration and escalating intensity, never by localized, mitigatable pain. To understand this rhythmic escalation, we must look beneath the macro-muscle tissue. Rapidly surging oxytocin molecules lock into myometrial cellular receptors. This surge of oxytocin acts as a powerful endocrine driver, overpowering any random cellular spasms. The hormone forces previously chaotic muscle fibers to fire together in synchronized, powerful biomechanical waves. These waves coordinate into a specific directional force, driving downward from the top of the uterus. This cross-section illustrates how that downward muscular force directly manipulates the physical position of the fetus. With each successive oxytocin-driven contraction, the fetus is forced incrementally lower into the pelvic inlet. This intense mechanical displacement connects directly to the sensory experience of the patient. The continuous fetal pressure against the pelvic inlet causes the severe lower back pain characteristic of true labor. Deep structural bone and nerve compression operates entirely differently from the superficial frontal abdominal tightening associated with false labor. This specific pain indicates that the biological geometry of the pelvis is altering to accommodate delivery. The mechanical displacement provides physical proof that the endocrine positive feedback loop is functioning correctly. True labor pain is the direct sensory result of biomechanical displacement, proving that the hormonal cascade is physically repositioning internal structures for birth. As downward pressure builds, the structural strain shifts from the contracting myometrium at the top of the uterus to the cervix situated at its base. This 3D schematic shows downward contractions driving two biomechanical processes: effacement, where tissue softens and shortens, and dilation, where it opens. The cervix morphs from a thick, closed structural tube to a widened aperture. This degradation naturally dislodges the mucus plug, a viscous barrier protecting the fetus. There is a major clinical misconception regarding the specific vaginal discharge. While the expulsion of the plug confirms structural preparation is underway, it does not guarantee immediate delivery and can precede active labor by several days. The ultimate structural failure is the rupture of the amniotic sac. The semi-transparent membrane stretches to its limit, tears, and releases a rush of fluid. Clinically, this rupture can manifest dramatically as a sudden gush or subtly as a prolonged leak. Regardless of the volume expelled, the breach of this membrane removes the final protective environment for the fetus. Unlike the early warning of the mucus plug, amniotic rupture is the definitive structural milestone that signals imminent delivery and mandates immediate medical contact. Evaluating the complete physiological picture requires merging the muscular, endocrine, and structural data into one cohesive diagnostic framework. Diagnosis relies on the contrast between localized, responsive false labor and the unyielding progression of the active state. This diagnostic dashboard visualizes the core temporal markers, highly regular contraction intervals that escalate in frequency and intensity. Next is the mechanical marker, undeniable lower back pressure caused by fetal descent. Finally, structural milestones confirm the system's commitment: cervical alteration, plug expulsion, and amniotic rupture. Mapping this rigorous biological cascade transforms patient confusion into clinical confidence and precise action. Rather than succumbing to panic, observe the body's data. True labor always leaves a measurable, progressive trail. Timely medical intervention should only be sought when objective biomechanical milestones prove the body has fully committed to the parturition cascade.